I like refractive surgeries to a great extent because these are kind of surgeries which have adorable results and are unsurpassed by any other surgery. And here we will see this is one surgery which all of us can do without much investment. This was a lady who presented to us with very high myopia, and it was 20 diopters, and this is the anterior segment photograph of this eye, and this is the surgical part. We are making the incision at the steep axis. It's a clear corneal incision, and the surgery is clear lens exchange. And this has to be done with some caution because it is very suitable for myopes and hypermetropes both. But the problem is that any surgical intervention in patients with high myopia can have serious retinal consequences. And as a result, one has to be very, very cautious in evaluating the retinal issues, especially the peripheral retina, so that there is no unwanted complication, and most dreaded one of them is retinal detachment. So this patient was screened for that, and lesions were found which were lasered properly so that there was no risk involved right now. And these patients also should be motivated to get the fundus examination done on a yearly basis so that any event which occurs can be detected before its occurrence and preventive laser can be done. So here we can see that an incision has been made, and just like a routine cataract surgery, the capsular excess is being done, and these are usually younger patients, and so it is desirable that capsular excess is done a little larger in size, as there may be capsular phimosis also. The surgery involves preoperative evaluation, as I have mentioned, retinal peripheral examination, and also IOL power calculation, which has to be done with some great concern because that is one of the main purposes, that the patient should be left emmetropic or nearly emmetropic. Especially one should take care that if the patient is left little myopic in these situations, he or she may be very happy. Exact emmetropia may not be desirable by these patients, and the greater advantage over rest of the surgeries involving including the corneal refractive surgeries when compared to clear lens exchanges, that the cataractous change in the future can be eliminated, and this patient has been made something like a cataract proof because we have removed this natural crystalline lens and there is no possibility of cataract in future. And so when comparing the other refractive surgeries like corneal refractive surgeries or phakic implantable lenses, these all will have an issue of future development of cataract and of future possibility of need for surgeries. So usually the lens is clear and nucleus is not very well formed, so the surgical part is not very tricky, although there are some issues because soft cataracts have their own issues. They are difficult to crack, rather they are so clay-like that they will simply not be able to crack. They have to be aspirated properly, and here I am demonstrating that you can aspirate this lens matter without using a side port. There is no nucleus to crack it. So once you have removed bulk of the nucleus material, then one should safely switch to irrigation aspiration, which has a lesser bore, so the fluid being aspirated and possibility of surge is reduced. Here, as much possible, lens matter is being removed so that the process is faster. And when we see that the lens matter is minimum, one can switch to irrigation aspiration cannula. Younger patients have their own issues. They are more apprehensive. They have more strong blepharospasm and uprolling of eyeball. But this is all can be taken care by giving the patient some time to adapt and gaining confidence. And this surgery is being done under topical anesthesia, as it is a routine cataract surgery. It's similar to routine cataract surgery, and this is well tolerated by most of the patients. Initial apprehension is usually taken care once the patient has experienced a part of the process, because then they can have the clue that what is the amount of discomfort they will have. Because the elastic is sclera, so it is always desirable to keep the chamber inflated all the time, because the eyeball will collapse. And here incidentally the incision was very short, and again this short incision is because these patients who have blepharospasm have a Bell's phenomena, which causes the eyeball to roll up, and this causes the blade to be aligned in a manner that long entry is not possible. The IOL has been implanted in the back directly, and this is a trifocal lens, and it is just a formality to center the lens. The trailing haptic has been positioned in the place by tilting the injector tip at the moment when the trailing haptic is ejected, and one has to remove the viscoelastic material so that there is no post-op inflammation and IOP spikes. This surgery is being done under Apasami Associates robot machine, which is a posterior anterior segment machine with inbuilt laser. At times, a short incision can cause this problem or iris prolapse, and one needs to burp the anterior chamber and then deposit the iris. This is the day 1 post-op picture, and at the end of 7 days, the patient had a vision of 6/12, and there was some amount of residual myopia left behind, so the unaided vision was 6/24, which I think is not bad, because these patients who have been myopic for the rest of their lives may be more comfortable with some amount of residual myopia. Thank you.